introduction are necessary, but maybe this is the protocol. His Excellency, the Executive Governor of Sokoto State, being represented by Dr. Bello Muhammad Marnona, the Honorable Minister, represented by Dr. David Atuo, MNI, distinguished members of the higher table. I think the protocol has been established, but I must thank the NEC, the President and NEC for allowing me to deliver this lecture and for the confidence reposed in me, despite the fact that this is not just urology. So I'll go through an outline from introduction to health workforce, description, to conclusion. And what is the issue really? Why are we here? I think we are here because our health workforce is at a crossroad, I must say. Because on one hand, we have an expanding population, putting stress on the workforce, health workforce. We have rising disease burden, also putting stress, and growing complexity of medical education and service delivery. This also something is putting stress. And on the other hand, we have acute shortage. Despite all those issues, we have acute shortage of health workforce, which we all know: brain drain, industrial disharmony in the system, fragmentation of roles, and weak interprofessional collaboration. Collaboration is actually weak. So therefore, this thing speaks not only numbers, but the structure, the governance, the relationships, leadership, and the culture within our own system. What is this health workforce? According to the WHO, is all people engage in actions whose primary intent is to enhance health. And we have doctors, dentists, we have nurses, midwives, we have pharmacists, laboratory scientists, we have other allied health workers. We also have community health workers, and even administrators. Administrators are also part of our workforce, and the academics in the university. So, what is the issue really? Where are we? Africa bears 25% of global disease burden, but we have only 3% of global health workforce. Therefore, we are in this, we have a lot of gap, and Nigeria mirrors this gap. What was the current state? The current state of health force in Nigeria is that it is bedeviled by quantitative challenges, qualitative challenges, and systemic challenges. Starting with quantitative challenges, we have very poor doctor to population ratio, and Nigeria has one of the lowest, and according to an observation by World Bank. So, what is this ratio? The ratio expected, according to the WHO, should be 1 to 1,000 or less. But in Nigeria, we have 1 doctor to sometimes up to 10,000 in the population. And for nurses, it's also similar. Instead of 1 to 300, we have 1 to 4, up to 4,000. And annually, Nigerians migrate, around 4,000 Nigerians, doctors, dentists, migrate out of the country, putting a lot of stress on the system. And from a survey recently released, almost 80% of Nigerian physicians are planning in a way not to leave the system, whether to internally or to live outside. The same for nurses. If you look at that figure, you find that only 4 countries in Africa have the ratio required of 1 to 44 per 10,000. And Nigeria is down low there. It's only about 16 per 10,000 population. So this is compounded. We have low figures already, and it's compounded by brain drain, serious brain drain. And Nigerian doctors licensed in UK, about 12,000 from recent figures of Nigerians are licensed to work and working in UK. And over the, let me say, over the last 9 to 7 years, as stated by the Minister himself of Health, about 16,000 Nigerian doctors immigrated to different parts of the world. And we have an annual immigration rate of about 4,000 per year. If you look at this figure, you will find that the immigration to US, Canada, to Europe, India has the highest, but Nigeria followed by Nigeria and then Pakistan. But the real issue is that if you look at per population, because of their large population, almost a billion, and our own of 220, 250, so you found that Nigeria has the highest migration rate of any country in the world. And this is a real serious issue. So apart from the number and the migration, we also have maldistribution of the workforce. And most of the doctors are working in cities. In Sokoto, I'm sure almost 90% of the physicians in Sokoto State are working within Sokoto, or similar figure. But I'm happy that in Sokoto, this issue is being addressed, because there is plan to allow doctors to work for 2 years or so, and other health workers in rural areas. There's a good plan for that. Now, therefore, there is inequity in the health system, and this is driven more by welfare, workforce maldistribution, sometimes than absolute scarcity. We have quantitative challenges. The qualitative challenges are burnout, a lot of it, dissatisfaction with poor morals. We are dissatisfied, some physicians, health workers are dissatisfied with the work, the salary structure, etc., and the infrastructure they are working in. And this creates a very poor morale. And then there's also an aging workforce in public institutions. Now, this burnout is an issue, and it is said that Nigerian physician, for example, is working is carrying the burden of regulatory frameworks and have clear role of all this. This is important because, it leads to title inflation, public confusion about authority, overlapping scopes of practice. When you create some of these things, you have to overlap the practice. And that is what is happening now. There are many areas where these practices are being overlapped, and promotion also becomes, and promotion leadership disputes are created, and legal regulatory ambiguities exist. And therefore, the real problem is that when system fail to define roles, if we fail to define clearly the roles of each, then the professionals will be forced to defend their own territories. So we don't want, it's happening in a small fashion now. We don't want the profession to be defending their territories. Let it be a systematic. So this is coming, we have to accept it, and it is coming. It's coming globally. It's not only in Nigeria. We have doctor of medicine, MBBS, MD, etc. But we also have doctors of other things now. A lot of, including doctor of naturopathic medicine, doctor of Ayush medicine in India. In US, this is the reality. In US, almost 26 states and territories, you can decide to become either an MD, doctor of medicine, or an MD, doctor of naturopathic medicine. So it is coming to us. We should conceptualize it very well and make sure that there are no conflicts. Even in Nigeria now, you can do BSc, complementary and alternative medicine, and go to some universities like Jos and do your PhD, MSc. I hope I'm correct, but I think I'm correct. And then you are a doctor in complementary and alternative medicine. So it is coming, and we just prepare for it and harmonize. We just harmonize the matter and make sure that the patient safety is dependent, because the patient safety depends on these roles. The health system must be well coordinated, and academic tackle must align. Effective health systems in all over the world, they align the regulation and service delivery. So we really have to do all these. These are emerging issues. They are not necessarily problems or conflict, but we need to smell them early and try to correct them. Another issue that maybe was mentioning is the PhD and fellowship issue, and the debate around PhD and fellowship is still continuing, and there is misalignment between university promotion criteria and clinical pathways, and this is partly what is creating the debate. And there is absence of a unified framework for academic and clinical careers. It's not well unified. We need to unify it. But the debate will continue. We should realize that the PhD represents excellence in clinical competence. I mean, fellowship represents excellence in clinical competence, with essentially for tertiary healthcare delivery system. While PhD, advanced research methodology, academic leadership, knowledge creation, innovation, and academic leadership, and essential for teaching and research. So, what is the issue really? So, some postgraduate colleges try to solve the problem, including theses, but honestly, most of what the postgraduate colleges are doing, I don't think it will solve the problem. I don't think it will kill the debate. So, what do? We look at what are other people doing globally. What is the global best practice on this? The advanced systems, they try to handle this differently. They keep fellowship, clinical specialization, and service leadership. Well, PhD is academic scholarship and research leadership. And many clinicians actually hold both. Clinicians, scientists hold both, depending on their role. So, we have an advantage here, and the career tracks are parallel, not hierarchical, and that the lack of PhD, but in those systems also, the lack of PhD does not limit progression of clinical lecturers. It doesn't limit their progression, as is being proposed in some quarters. So, the fellowship and PhDs have different but complementary purposes. And for us in the clinical area, Mdcan members will have special advantage to have both PhD and to have your fellowship. Others may not have this advantage. I think you should use it. It has a lot of advantages in doing that. So this is because in global best practice, the strength of medicine lies in organizing excellence in both service and scholarship. It's not just service, but also excellence and scholarship. If you combine two, then the sky will be your limit. Higher performing systems, therefore, adopt this. And what Mdcan position should be, I propose that Mdcan, if you are going to have, and that you have a policy recommendation, and fellowship should remain. PhD has its own role, neither diminishes the other, dual track pathway, the continued recognition of fellowship for clinical, and optimal targeted PhD for research intensive tracks. Those that want to go into research intensive track, they should have their PhD. So the balance can be strike if there is joint Mdcan, NUC, Mdcan, National Postgraduate Medical College, University framework to resolve these issues and have clear roles, well defined. So, and also to advise our residents, ideally in some of these also advanced systems that work, before you finish your fellowship, you have a PhD. And I think that should also be one of the things that we can do. So there are emerging policy tensions therefore. This expansion of these programs, increasing diversity and growing overlap of academic titles, and titles without clearly defined roles create confusion rather than solutions. So this is for this. Then the need to collaborate. The need to collaborate is also important. And this is in our health system, it's a missing link. We need to collaborate. And you can see this image of us following a training in the theater urology center of excellence where everybody was involved in the training, the nurses, the physicians, the surgeons, the radiographers, radiotherapists, everybody was actually, including the administrators. And we work together, and we have that advantage, and we don't have any much conflict. So collaboration is necessary because we need to share goals, respect mutually, clear communication, complementary roles, and collective accountability. And team-based care, nobody is taking the role of another person. You can see you can't take the role of those standing. You know, the strata is well outlined, and everybody has his own role. And so this is how things should be coordinated. And this is important for also university health coverage. But why are we not collaborating in our own system the way we should? This is because of mistrust and because of overlapping mandates. So the mandates are overlapping, and others will feel you are doing their work, they will not cooperate with you. There's poor conflict resolution mechanism, competition for leadership position, inconsistent policies, and lack of professional education. So, but the problem is probably most of the problems from the top. Many conflicts share single cause, and that is because of fragmented structures from above. So you have education policies by NUC, Ministry of Education, training standards by Mdcan, postgraduate colleges, Nursing and Midwifery Council, Radiographers Board, etc. So you have employment condition determined by Ministry of Health, Head of Service, and Ministry of Head of Service, and also industrial relations determined by labor code, unions, and these often they don't operate together. So you may have some policies here that are not really, you are not considering the others when it is. So therefore, the Mdcan should call for inter-ministerial and inter-regulatory coordination, where as to act, and the Mdcan can act as technical partner in this, so that we don't pull apart, we pull together and move forward. So how do we, there are also other evidence-based strategies that we can adopt for strengthening collaboration, including interprofessional education, multidisciplinary teams work, multidisciplinary teams in the system can also enhance collaboration. And joint services committees, digital collaboration, the e-health has helped in collaboration because things are defined in the e-health system, and you just play your role and pass. It's not like where you finish seeing the patient and you pass to another person. But in e-health, somehow there is some digital collaboration. So, and this conflict resolution frameworks should also be instituted. You know, learning together is known to be very important, and that students who learn together are more likely to work together. This is what WHO observed. And imagine if you are doing cardiopulmonary resuscitation and the physicians are there, the surgeons, the nurses, the anesthetic nurses are there, the technicians, the pharmacists, everybody is there, and we are learning this resuscitation together. You are likely to work together in real time. So then another issue that I'll go into before maybe summarizing is retention. This retention is important because it's also a silent crisis in the health system, where we are not retaining the people who train our health workers. We are not retaining them, and the main factor, one of the main, or even the main factor, is poor remuneration and poor work environment. You know, surprisingly, it's silent because surprisingly, retention is said to be more effective than recruitment in improving the health system. So if you have a recruitment process but you cannot retain, you are really wasting time. Define our roles, and collaboration improves outcome, fair remuneration improves retention as the main factor, allowing people to live. The strength of our institution and leadership. I'm happy that some of these things are being resolved, determine whether our own system is sustainable. So, final slide, finally, I think the workforce can be strengthened by quantity, as we mentioned, which we lack, by quality, which locally is on our side, and by the clarity of its structure. We have to have very clear structure with clearly defined roles. So God bless. God bless.